Good afternoon, everyone. I would like to welcome you to the third AGePOP Open Research webinar. Before we start, I would like to present a brief overview of AGePOP. AGePOP is the acronym of the Marie Curie Action funded by Horizon 2020 and stands for Drug Absorption in Geriatric Patients and Older People. This is a training network innovating drug development for the advanced age population. The objective of AGePOP is to generate for the first time information on the actual dosage form intake conditions for older people and geriatric patients and on physiological characteristics of their gastrointestinal tract relevant to oral drug absorption. AGePOP team consists of 3 academic institutions with research excellence in oral drug absorption and development. And these institutions are KU11, University of Greifswald, and the National Kapodistrian University of Athens. On top of that, we have with us 3 leading pharmaceutical companies, Bayer from Germany, Roche from Switzerland, and Merck from Germany. In addition, 8 partner organizations from 5 countries and from 3 different sectors, meaning the clinical health sector, the leading pharmaceutical companies, but also one SME with expertise in training, complete the AGePOP consortium. So we have with us Janssen, UCB, Novartis, Accelopment, AstraZeneca, AbbVie, and the hospitals from University of Greifswald, but also the General Hospital of Athens that is named Red Cross Hospital. 11 ESRs from 8 countries are on board, and our aim is to provide them with the opportunity to become the first trained experts on oral drug delivery of drug products to older people and geriatric patients in Europe. 2 of our ESRs are going to present today their research in this third AGePOP webinar. AGePOP is funded by Horizon 2020. And the budget is 2.8 million euros, and is a Marie Curie Action European Training Program. We started on February 2021. For further information and updates, you are welcome to visit our website and follow us on LinkedIn and Twitter or X. And now it's my pleasure to introduce our moderator for today, Andre Dahlman. Andre Dahlman is a scientist for systems pharmacology in the Department of Pharmacometrics Modeling and Simulation at Bayer, and Andre is based in Lille, France. Andre earned his PhD with a focus on PBPK modeling in special populations at the University of Münster, Germany in 2017. Thereafter, he pursued his research in modeling and simulation as postdoctoral fellow at the University Children's Hospital in Basel, in Switzerland, before joining Bayer in 2018. In 2022, he is elected as a Bayer Science Fellow in recognition of his scientific outreach and leadership. Within Bayer, Andre develops and applies mechanistic models throughout the clinical development phase to characterize drug candidates, particularly regarding their biopharmaceutical behavior and drug-drug interaction risk. He serves as principal investigator or in-kind contributor in 5 grant programs in the European Union and the European states and the United States. Together with scientists across academia, industry, and regulatory agencies, he has co-authored over 45 peer-reviewed articles and book chapters. And now I would like to invite Andre to introduce our ESRs that are going to present today.
Yeah, thank you, Maria, for the nice introduction, and also welcome everyone from my side to this webinar. We are very excited to have you with us today. So now let me introduce our 2 speakers. With us today, we have Donnia Robbins and Cleo Demeester. Donnia Robbins is a PhD student at Merck in Germany, where she is supervised by Andreas Lehmann and Katharina Krolik. She's also enrolled in the National and Kapodistrian University of Athens, where she is supervised by Maria Verzoni. In her PhD work, she focuses on the application of physiologically based biopharmaceutic / physiologically based pharmacokinetic software tools to predict oral drug absorption in older people and geriatric patients, and the development of an absorption risk calculator to assess the probability of adverse effects in older people due to altered pharmacokinetics. We also have Cleo Demeester with us. She's a PhD student at Bayer in Germany. She's supervised by myself as well as by Thomas Wendel. And she's also enrolled as PhD student at the KU Leuven, where she is being supervised by Patrick Augustins. The topic of her PhD thesis is the development of an open access PBPK model to predict oral drug absorption in geriatric patients and older people. With that, I'd like to hand it over to Donnia, who will kick off the presentation.
Thank you, Andre. So as mentioned, Theo and I are very happy to present on the topic of physiological-based approaches for predicting absorption in older people. So what you should know and why. So if we look to our early stages of life, when we were neonates, when we were babies, there are a lot of physiological changes happening. So we're growing, and this has been investigated quite extensively to see if there are changes in pharmacokinetics and changes in absorption. However, when we move from childhood to adolescence, adulthood, though it's been investigated, there isn't much of a change in absorption. However, now going towards the next extremity of life, we're growing, but absorption, in fact, has been quite underaddressed. And this is the purpose of the AGePOP consortium. And so today, Cleo and I will discuss physiologically based pharmacokinetic modeling as an in silico tool, which is able to take a variety of data sources, so from preclinical sources, from clinical studies, in vitro studies, and it can act as a bridge in order to further investigate this question. So today we will first begin with a brief overview of aging and clinical studies, the current status. Then we will introduce the basic methodology of PBPK modeling. This will then lead us to an industry survey where we will talk about some of the platforms that are available, and followed by a case example of building a PBPK model in a special population, such as the older population. And finally, we will end with a discussion of the population-specific challenges to model development.
And we would like to start with sketching a problem. As everybody probably knows or can imagine, are the older adults the main users of medication. So the older population are using drugs the most. And actually, this is quite interesting because the older adults are not well represented in clinical trials. So a lot of dosing decisions and drug development are based on healthy young adults that are included into clinical trials. And even though regulatories such as ICH and FDA are supporting more older adults in clinical trials, it's difficult. For example, ICH has guidelines that say a certain amount of older people are needed in the clinical trials and also supported, especially in phase 2 and phase 3 of the clinical trial. And also FDA is saying that a meaningful number is very important of older people with a certain disease in clinical trials. It's, as said, quite difficult to include them because of various limitations. And these limitations can be various, as said. Older people are sometimes unable to consent, which makes it quite difficult to then participate in the clinical trials. Also, some older people are functional dependent, which makes it then difficult to come to the clinical trial site. And older people have often underlying diseases or are taking various medications, which both can lead to adverse events of the clinical trial, which is also not ideal for a clinical trial. So this results actually, all these limitations result actually to an underrepresentation of the target population, so the older people. And we want to give you 2 examples. So for example, in type 2 diabetes trials, only 1% of the study population is older than 75 years of age, which is quite low. And also simvastatin, which you can see here on the right in the figure, you can see that the trial population is approximately 60 years or younger, given in blue. And the lipid lowering population, so the target population, are mostly 60 years or older, given in green in this figure. So this is quite challenging. So it's quite challenging because we do want to give the older people the right drug and the right dose, and to give them a personalized medicine. So the approaches that are now been taken to give the older population the precision medicine are, for example, biomarkers. It's important to do research for biomarkers, which biomarkers are associated with aging and which biomarkers are associated for certain diseases. It's also important to look at expert advice. There are already multiple criteria, and for example, the Pierce criteria that sum up the risks for certain drug intake in combination with other drug intake. So it's important to also take this into account. Also important approach are pharmacogenomics. Sometimes we can already, by looking at the genomics of a person, we can already know if a person is a poor metabolizer, for example, and then already the dose can be adjusted to this person. But the main focus of today's topic is the model-informed approaches. So as Donnia said already, we will focus on physiological-based pharmacokinetic modeling, and there are also other model-informed approaches. Computational approaches just like disease progression modeling, quantitative system pharmacology, which take into account also the comorbidity, polypharmacy, and the age of older adults to, in the end, give the right dose to the older patients. So physiologically based pharmacokinetic modeling is actually based on the physiology of the knowledge of the physiology of aging. We know already a lot of things that are changing in the older population. We know that some capacities and capabilities are reduced in older adults and are declining by age. So, for example, your liver and your kidney function is reduced when aging, but also your cardiovascular system, and your blood-brain barrier is altered. And also an important thing is that your body composition changes. You have a decline in muscle and an increase in fat, so that your ratio is changing. And what is AGePOP looking mostly at is your gastrointestinal tract that is also altered while aging. A good thing to keep in mind while looking at all this physiology and all these changes over age is what is changing with your chronological age. So the amount of years, how old you are, and what is changing by the external factors. So for example, if you are taking a certain type of medication, or if you are living in a certain type of environment, because this can also affect your physiology and is called biological age. So as said, all this physiology changes is the basis of a PBPK model, because PBPK model takes this knowledge into account. And we want to shortly go over the methodology of PBPK modeling. So PBPK modeling is a bottom-up approach and a tool that divides the body in different compartments. So as you can see here, all the organs are different compartments. And all these compartments are then again subdivided in subcompartments. So you can see here the plasma, the subcompartments, so the plasma, the interstitial and the intracellular compartment. And all these compartments are interacting with each other by ordinary differential equations, so ODEs. And all these compartments actually describes the ATME processes of a drug. So the absorption, the distribution, the metabolism, and the excretion. And it explains over time where the drug is in the body and how it behaves in the body. This is actually a very useful approach to look at what a drug is doing in the body, and especially in special populations. And as the older population is a special population, it's also a perfect tool for the older population. To start with, how do you do that, PBPK modeling of the older population? We would like to go through the workflow. So it's often you start with unhealthy young adults. So you know a lot about the young population. You know certain blood flow rates, you know surface areas, you know organ volumes of the healthy young populations, and these are called system-specific parameters. Then you are interested in what the drug does in the body. So then you take into account also the drug-specific parameters. So, for example, your pKa and your lipophilicity, which you know from your in vitro studies of a certain type of drug. Then the system-specific and the drug-specific parameters interact with each other, and you can calculate, for example, the partition coefficients and the fraction unbound. And then you have all these parameters and all this knowledge, which you can put into the PBPK model as an input. Then the PBPK model is using all this information and calculating all with the differential equations where the model behaves and predicts what the concentration of the drug is in the body of your organ of interest. And most of the times this is your plasma concentration. Then you have a prediction of your plasma concentration over time. You look if that matches your observations, which you measure in the healthy young adults, and then you re-evaluate when this doesn't matches, and you look back at your input parameters. When validated, you can scale to an older adults by taking into account what changes in the older adults. So already mentioned, you have intrinsic and extrinsic factors that could change the physiology of the older adults. So for example, you know that the older person is smoking, which causes some physiology changes, but also some medications or drug interactions, diet, or intrinsic factors such as age. You know that the physiology is then changing, so certain system-specific parameters are changing. You can change this then subsequently in your model input, and then the model will give you an output with a prediction of this certain type of drug in the older adults. So we are especially interested in the absorption-related changes, as AGePOP is focusing on absorption. And as you may know, already seen in previous webinars, we know from certain parameters that they are changing when aging, and certain parameters are also not changing. Some of them are summed up in this figure. We know, for example, that the splenic blood flow is decreasing in the older adults. We know that the large intestinal transit time is also longer in the older adults. We know that the volumes of the organs are also decreasing. For example, also if you're taking a meal, the pH is increasing, and the rate of return to a gastric pH is also slower in older adults. So we all have this information known from literature. This we can then put again in as an input in the PBPK model, and then an absorption related models, as you can see here from Donnia et al., which is implemented in PKSim. You can put this as an input in the model, and it will give you an output and prediction of your absorption for the older population.
Okay, so thank you for the overview. Now that we understand a bit more about the theory of PBPK modeling, now let's look at the current platforms available. So luckily, as you can see, a lot of data is required to build such mechanistic models, such bottom-up models. But thankfully, there are companies that provide platforms that allow us to already have a template that we can build our models on. So as mentioned previously, they are compartmental models, and you can see that this would be the major similarity across all three. However, the number of compartments, the choice of the discretization of the gastrointestinal tract, for example, for the ACAT and the ATOM models of GastroPlus and SimSip, they have 9 compartments from the stomach to the colon, while for PKSim, it's 12 from the stomach to the rectum. Also, PKSim would be the open source option here. Another point to mention would be, along with physical compartments, because we are talking about physiologically based modeling, we still have these theoretical compartments. So if you look closely, you can see compartments for dissolution, precipitated drug, and such nuances can lead to differences in their predictions. However, as I mentioned, these are the major platforms available. So in the following slides, I will present the results of an industry survey, as well as a review of the literature in the current capacities of these platforms and to incorporate any age-associated change in absorption. So in order to understand this, green would be the user-friendly, very easy to do changes. So the mechanistic significance of the in vivo phenomena that's being emulated may still be retained. There may be automatic data conversions or scaling. So just making the modeler's life very easy. Yellow would be in between. So with some difficulty, maybe you need to subscribe to a supplemental module or software. All of these companies have a suite of software available for different purposes. Also, perhaps it's no longer a mechanistic model, but it may still be fit for purpose. And red would be those changes that are implemented with great difficulty. So you're basically building it from the bottom up, or there's no clear option available at the time of our survey. So beginning with the physiological changes, as mentioned, luminal pH would be a very major parameter, and it is something that has been investigated, and thus we see it's green across all platforms. So this is very easily modified. And for SimSip in particular, they have mentioned that they've incorporated an age-associated effect. So this change in the rate of return to preprandial pH has been in fact incorporated. Now when we're looking at the transit times, so gastric emptying time, small intestinal and large intestinal transit time, these are also major factors, upstream parameters that can affect the time for dissolution, for permeation. So these are also very easily modifiable. A note from GastroPlus on this one would be that they do indirectly account for age, because gastric emptying is dependent on the meal composition when looking at food effects, and thus they have a correlated total daily caloric intake and age. So with this, you're able to at least sort of indirectly account for age when looking at food effects with GastroPlus. Biological, so this is a very important parameter, again, for particularly the solubilization and dissolution of drugs. And the commercial platforms, GastroPlus and SimSip, they have mechanistic models for this available. PKSim is in red right now because you would need to build from the bottom up. This isn't to say that, of course, it's not in the works with any of these software. There could be improvements coming very soon. Also, with biostabilization, you're still able to use your biorelevant in vitro solubilities to account for this. aqueous fraction, another parameter that can affect concentration gradients as well as the solution of the drugs, very easily modifiable. Moving along to intestinal enzymatic and transporter activity. So this would be a very major parameter. In fact, drug-drug interactions, which these particular species tend to be involved in, it's still one of the major applications of PBPK modeling. Thus, all platforms address this quite well. You're often able to relate it directly to the relative expression data, as well as look at different models, whether you want to model it as a first order process, a Hill, or a Michaelis-Menten process, the kinetics. Organ volumes, also very straightforward. I will note that with these parameters, even though we're mentioning modifiability, oftentimes with these platforms, the advantage is that there's some correlation. So organ volumes would be one of these that would be related to, let's say, your macro, height, weight, surface area. So you need to keep this in mind and when you're modifying it. Surface area of the intestine, this would directly affect, of course, permeability. And there have been a lot of studies regarding this, as Cleo mentioned, and thus this is also easily modifiable. Salivary secretions in pH, this may be an interesting one. It doesn't have a direct link to changes in pharmacokinetics like the other parameters. However, there are studies that show that the composition, the flow rate, pH, there can be some modifications with regards to age. And for this flow rate and the pH in particular are easily modifiable with the first two, and an indirect change can still be accounted for with SimSip. Tight junctions and paracellular absorption, so this is more passive permeability. This would be related to this inflammaging leaky gut hypothesis that the AGePOP consortium was investigating as a whole and that we've just mentioned. And for this, the commercial platforms you're able to directly modify pore size. With PKSim, you're able to, but only if you use supplemental module MOBI. In PKSim, you can directly modify the actual rate of paracellular absorption. And then the last one may be a unique one or a surprise to some of you. So the microbiome composition. This is a subject of emerging research. So here I present an aging clock from the reference study. This was able to predict age with a mean error of about 6 years. And it was just based on the quality, so the variety and the quantity of certain microbiotic species. And the microbiome has now been implicated in the frailty axis, and it actually has some publications showing direct influences on pharmacokinetics. So it can metabolize drugs, it can bind drugs, transport drugs. Thus, it's growing in interest among scientists, but unsurprisingly, it's not been incorporated as a mechanistic model yet across these platforms. However, you're still able to have workarounds and implement metabolic processes, for example, in certain locations where you expect the actual phenomenon to occur. So now moving along to more formulation aspects and other features that may be interest to modelers and formulation scientists. So we're talking about oral absorption. The buccal sublingual route, it takes just a small fraction of the overall drug products available. But in fact, it's been shown that oftentimes you're still swallowing a lot of the drug, even with this dosage route. For this, GastroPlus has the mechanistic oral cavity compartmental and transit model. Otherwise, you would need to work a little bit with the other platforms. Controlled release, on the other hand, is very well addressed. Particularly, you're able to use the very popular Weibull function to simulate your drug release. Powder and food thickener would be one of those very specific to this population, and we will get into that a bit more deep in a little bit. But due to difficulty swallowing, there's a risk of this occurring, of them modifying the dosage form. And because it's such a special scenario, you wouldn't expect it to have a specific model, but looking at the platforms, there's still some flexibility here. Excipient effects, especially those that are not modifying solubility directly, you're able to kind of work with. So there's some that can modify, let's say, the transit times. This can directly be modified. However, a lot of them can work in a very multifactorial way. So a mechanistic model may be desirable, but it would take some effort on your part. And you may need to use some of the more supplemental customized tools like MOBI for PKSim or the Lua tools available in SimSip. And finally, age scaling is thankfully available. So this should be a good starting point if you want to develop a model for this population, though we do say that it's mostly focusing on post-absorptive processes. So in the end, you'll see that there are flexible options available already, good starting points for model development. A really important note would be that even though certain age-associated changes in absorption were not mentioned in these last few slides, it doesn't mean that it was not investigated. In fact, it has been for a lot of the platforms, but they did not find a difference, or they decided to assume the same for the young population. And finally, a PBPK model is still a model. So we need to be able to balance the complexity with the purpose. So not in every scenario you need a mechanistic, very complex model. And with this, I will turn back over to Cleo.
Thanks. So as Donnia said, and as you all saw, the software is there for PBPK modeling, and also the knowledge of all the physiology changes is there. Previously already various publications were also successfully in predicting pharmacokinetics in the older population by PBPK modeling. And you can see here in the slide, you can see them summed up. So various compounds were modeled by various authors, and also in different modeling software. So on the 4 big ones. All the methods were also different from each other. Some used different scaling approaches, and also the software used sometimes different scaling approaches. Some also looked at more specific type of population. So for example, a Chinese population and their CYP1A2 abundance, or some looked at a specific disease, for example, renal or an hepatic impairment in the older adults. And we would like to go through one of these publications to go through the workflow of it as a case example and go through every step. So we will go through a case example of Schlender et al. The first step in his research was use literature research. He looked at various publication platforms such as Google Scholar and PubMed, and looked at the quantitative measurements of the older population, so 65 years and older, but also at the younger adults aged more than 30 years older. As said, he looked at the quantitative measurements, to the anthropometrics, the anatomy and the physiology, and he included 116 studies. Almost 17,000 subjects were of an older age, and 46,000 subjects were of a midlife age. As a second step, there was an analysis of all these quantitative measurements from all these different studies. And at first they looked at the body weight, which you can see over here. You can see that there's a different mean body weight for female and for male, and that your body weight is increasing to approximately an age of 55 years old. Then when you're turning 55, approximately 55 years or older, then your body weight is decreasing. And this is also for all the organs, which in the end, when you add them up, are your body weight. So these organs are shrinking over age. A linear function was calculated per decades for the female and the male, and this average value was taken into account. Also, your body height is decreasing when you're aging. Here you can see that this is happening in an earlier stage. So if you are around 30 years or older, your body height is decreasing by approximately 1% per decade. And for the female, this accelerates when after the menopause, where you have a decrease of your body height by 4% per decade. Also, this was taken into account, and also the glomerular filtration rate was looked at, which you could see here. Also, that is decreasing over time after an age of 30 years old. And this was not linearly described, but with a reverse sigmoid hyperbolic maturation function, as you can see here. Not given on the slide is also that the blood pressures are decreasing when you're aging, also by approximately 3% per decade. So this analysis and all this average functions over age were put into a huge database, which is now also the database of PKSIM, and was validated by looking at the predicted performance first for the intravenous compounds, which you can see here. So they modeled with a PBPK model the furosemide and morphine, and both had a different elimination route. Furosemide is eliminated renally, and morphine was is eliminated hepatically. And you can see here in the figure, given in black, the prediction of the whole database, all the different physiological changes they took into account for the older adults, and given in light gray for the younger adults. So it was predicted that for both compounds, a different distribution and clearance, which in the end resulted in a higher AUC, so an area under the curve. And you can see that the predicted performance was well for both compounds, but it was both intravenous compounds. So therefore, afterwards, they also looked at oral performance, and they looked at ciprofloxacin. Again, clinical studies were included of observations, PK observations of ciprofloxacin. And this case was predicted for the very young population and also the very old population. So actually the whole lifespan was taken into account and predicted. And you can see on the right top the AUC over age, and you can see that there was a right prediction of the area under the curve for the older ages. So also the database was validated by this also orally.
Oh, hopefully you can hear me. Now that we've seen a case scenario, let's talk about some of the difficulties with regards to model development for this population. So let's take Mary Ann. She is 80 years old. She's living in a care home. She has Parkinson's disease, essential hypertension, ulcerative colitis, and she's taking pain medication and antidepressant and verapamil for high blood pressure. So this is a typical case. It's not extreme in any means. However, you can see just looking at these 5 different factors, how it can affect the absorption-related parameters that we've been discussing. If you look just at the first row for oropharyngeal function, living in a care home as well as taking the drug verapamil has been associated with a decrease in this function. On the other hand, for gastric emptying time, we have 3 factors that is associated with a decrease, but 1 factor that's associated with an increase. So there would be some neutralization, but to what extent? There's no, how do we know that the first 3 factors for gastric emptying time, for example, is only accounting for 20% of the overall effects, and ulcerative colitis is actually the major factor? These are questions that really rely on data availability, which, as we said, is limited for the older population and can definitely lead to extensive confounding of models. So you would like your model to be able to have a direct link from the inputs to the outputs and have some reasoning behind it, especially for a bottom-up approach like PBPK modeling. But due to the combination of these intrinsic and extrinsic factors like polypharmacy, frailty, the microbiome, it can be quite difficult to decouple the effects. So other population-specific challenges, dysphagia. So I mentioned having trouble swallowing can be prevalent in this population. So this can affect pharmacokinetics. For example, we see for acetaminophen, once the drug was stuck in the esophagus, the pharmacokinetic profile was completely different. And of course, it's a special case, but it may be possible to use PBPK modeling early on in order to perform some risk assessment of this. Another case would be modification of the tablets, so crushing a tablet. This would, of course, also lead to changes in the release profile and the bioavailability of the drug. Medication adherence would be another factor that is specific to this population, where they're kind of known for not being as compliant, but in fact, it's not intentional. It's due to errors. It's due to social frailty, cognitive function, not really understanding the purpose of it. This was seen in an Italian study where after 15 to 30 days after hospital discharge, older people who were prescribed at least 4 drugs, they had a rate of non-adherence of 55%. And considering that many of them are supposed to take these chronically, 3 months later, it increased to 70%. So this is something that would also need to be addressed in the primary care level, but it's using PBPK modeling, we can also kind of try to predict this and see what would be the consequences for lack of efficacy or in other cases, toxicity. So frailty should also be mentioned. This is one of a really good example of how biological age is more important for parameterization of this population than just chronological age. So it's characterized by this reduction in the homeostatic capacity. This is due to accumulation of cellular damage that then leads to degeneration of systems on the organ level. And on the left-hand side, we can see how it's directly correlated with chronological age from a variety of studies around the world. And on the right-hand side, we can see how it directly affects pharmacokinetics with the drug metoclopramide. So the top curve with the highest exposure would be the frail elderly, while the other 2 curves they're actually the young and the fit elderly. So you can see the young and the fit elderly, it's quite similar to pharmacokinetics, but when we take into account this very exaggerated aging, pretty much, we see a change in pharmacokinetics. Sex is also a very significant covariate, and it's often investigated even in younger cohorts. So on the left-hand side, for example, we have the unstimulated whole saliva flow rates by both sex and age. And we can see that there is somewhat of a difference in the youngest cohort, but as we advance age, this difference becomes statistically significant. And this is something that's sort of reflected across the literature, that differences can be further exacerbated by age. So there's these interactions. On the right-hand side, we see PGP, so major effluxer in the intestine that can directly affect bioavailability. You could see for females, there is lower expression relative to males, and this can have effects regarding to your excipient choice and for, of course, PGP substrates in general. So to wrap up, let's consider some important questions if you were to develop a PBPK model for this special population. Maybe you've already thought of these questions yourself. So the first one will be related again to chronological versus biological age. What is the best age? What is the minimum? You can see depending on the region, this can vary. So for Japan, it's 75 years, while in India, Many studies have reported 60 years. And then if we looked at the special patient population for people with HIV, it would be 50 years. Another important question regarding to data, I mean, it's a model, so it's heavily dependent on the quality of your data. If we were to think about whether absorption is actually changing with age, you would ideally want to be able to follow a person's entire life cycle, let's say. But we know this isn't feasible for many reasons, financial and time resources. Thus, we tend to rely on cross-sectional studies. But in fact, as you saw with Cleo's example that she presented, you can use PBPK modeling to sort of interpolate the studies and do a in silico longitudinal study. So it really does help you to extract as much information from all the data sources that you have available. And then the final question I will propose would be, what is the optimal measure of change? So a lot of the studies are controversial in their conclusions, and each platform would have their own preference in how they would like to parameterize certain phenomena. So let's take, for example, change in gastric emptying. Should you use a static measurement? Let's say the time at which 67% of the contents of the stomach enters the duodenum. Maybe you don't see a change here, but if you look at the actual profile, so the rate of emptying, you see, oh, one is linear versus one being exponential. On the other hand, you may look directly at those, physiological or organs that is actually controlling the process that you are investigating. So for gastric emptying, this can be neuronal loss or reduced contractile capacity. Of course, this is going to be a subjective question, depends on the data you have available for your model, the platform that you're using, the model purpose, but it's definitely something to consider, and maybe you want to compare different methods during your development process. So to sum up, let's discuss very briefly some of the applications. A big one would be optimization of formulation. So considering that older people are actually our major clients as part of the pharmaceutical industry, it would be ideal to have formulations that are optimized based on their own physiology. And this is what PBPK modeling can do. You can look at the interplay between the physicochemical properties of your drug, your different formulations, whether you have different candidates with different profiles, and then you're able to sort of do a risk assessment early on and optimize to have the best drug for your patient population.
As mentioned before, therapy can be optimized. You can predict with a PBPK model what the pharmacokinetics looks like and how it differs from the younger adults. And this can lead also to a different dose, as mentioned before. But not only study and therapy optimization, you can also look at DDI, so drug-drug interactions, and analyze if a drug-drug interaction could take place for two types of drugs. For example, CYP3A4, there are a lot of perpetrator CYP3A4 drugs and a lot of a few victim CYP3A4 drugs. So as you can see here in the bottom, in the red line, the victim pharmacokinetic profile is predicted. For example, midazolam is a victim CYP3A4 drug. And as soon as you give this with a perpetrator, for example, itraconazole, you can see that the AUC is changing intensively. There's a much longer exposure. Cmax is higher. So when combining these drugs, you can already predict for the older population what would happen with a PBPK model. We talked a lot about pharmacokinetics, but pharmacodynamics are of course also important, which dose has the right effect and the desired effect. So this is pharmacodynamic modeling, and PBPK modeling could be an input to also predict your pharmacodynamics. A lot of information we told today. We also wrote a review about everything we said today. called PBPK modeling of oral drug absorption in older adults, which is an AGePOP review. So if you want to read it in your own pace, then we would like to refer to our review. It's open access, so everybody can access it. And with that, we come to an end. We would like to thank the software platforms, the representatives of them, so from Certara, Simulation Plus, and Open Systems Pharmacology, as they participated in our survey. And we would be happy to answer questions if there are any.
Okay, thank you, Donnia and Cleo, for this very insightful presentation. I'd like to open the Q&A session now. We have one comment. SimSip appears to have built-in excipients from version 22 onwards. So thank you for this information. Also, starting maybe with the first question, and that probably goes to you, Cleo. You mentioned that the organs are shrinking over age. So is that also the case for the luminal fluids that are contained in these organs, for example, in the gastrointestinal tract, such as the gastric and intestinal fluids?
Yeah, that's a good point. Right now, this is, as far as I know, but especially for PKSim, not incorporated for the older population. So the luminal fluids, so only the organ volumes are decreasing. It's of course important to take into account as it can affect solubility. So you said also gastric fluids volumes. Yeah, are they changing in the older population is also still a question, because age directly if age directly influences the gastric fluid volume is still debatable, but a lot of other factors could affect this gastric fluid volume. So, for example, an H. pylori infection or usage of PPIs, so proton pump inhibitors, which could decrease acid secretion. So yes, this could be a thing to take into account. For the intestinal fluid volumes, if they're changing, the older population is also measured already before, but with different sort of measurements. And a lower, for aspirational studies, a lower intestinal fluid volume was seen in the older adults. So this could be something to take into account if you're modeling this.
Great, thank you. We do have more questions from the audience coming in, and I just address them here as they come in chronological order. There is a question. Are there any case examples where absorption was so altered in elderly that it led to safety or therapeutic concerns, as this wasn't checked in the clinical phase of the drug development process? This might be a tricky question. I don't know if you have looked at that in your review. Might be beyond scope, but you might want to comment on it nonetheless.
Yes, it is. I think there's multiple factors here. Like, as we mentioned, there's the intrinsic and extrinsic. I think one that we would very much be familiar with would be PPI. So older people tend to be the primary users of this, and this is something that is actually checked within the clinical phase, and PBK modeling has been used in order to do this. But to say that there was a surprise safety therapeutic concern, I personally haven't found anything in the literature for this. I don't know if Cleo also has a comment.
Yeah, I agree on this. Like, there are some cases that, you know, for example, not by the absorption being altered, that there was really less absorption. So, for example, but also, as Donnia said, not coming by age, but more in case examples like PPIs. There are lots of studies that older adults are taking a PPI and then in combination with another drug, and then this drug is poorly soluble in of is really relying on an acidic environment, and when taking on PPI, then the drug isn't solubilized then anymore, and then the drug doesn't have an effect. So this is yeah, sort of concerning, but yeah.
Thank you. Another question refers to the impact of disease on the aging process. Are there any specific information in the literature on the disease impact on the aging, in addition to frailty and physiological, or say chronological aging? Have you come across any of that? I think
For this one, I would say yes. Let's say for renal impairment or hepatic impairments, oftentimes in the investigation, they will still include the older cohort. But the specific interaction between the two, I'm not sure if there are many studies specifically investigating it like this. For us, we wanted to focus on healthy aging as an initial. And then, of course, there's all of this multimorbidity that the population experiences. But this would require, yes, a lot more clinical studies and a lot more data.
Once again, I'd like to thank you also on behalf of the speakers and moderators for your interest in today's webinar and in this topic, and also for having engaged in the Q&A session. With that, I'd like to close this webinar. Have a good day and goodbye.
Thank you.
Thank you. Bye.